Howdy, y'all. I'm Dr. Jeff Jarvis, and I want to go over a new policy we just sent out, and then I want to provide some reminders about how we need to interact with sending physicians. First, let's hit the new policy. It's called the Transition of Care Policy. The intent of this policy is to provide a framework for interacting with other EMS agencies, with FROs, with clinics, with helicopter EMS, with hospitals. Basically, anytime we have a transition of care between two different sets of clinicians. The point is to increase the clarity of who is in charge of the patient care and whose protocols define that care.
Look at me, sure. Look at me, sure. I'm the captain now.
When all clinicians are under OMD protocols, it's gonna be easier, but we will all benefit from this increased clarity. Now I'm going to use two phrases here to make this a little bit more simple. The folks with the patient to begin with, those are the sending clinicians, and those coming to take care of the patient, to move them somewhere else, those are the receiving clinicians. Basically, this is using the same terminology as EMTALA, and it's using the same terminology we use when we're talking about transfers. So, even though the vast majority of the time we're going to be using this as not a transfer, I still want to use the sending and receiving clinician concept just to make this policy a little bit easier. Now, basically, whenever EMS arrives and the patient is in the care of another clinician, that sending team is in charge of the patient. They've been taking care of the patient and operating under their protocols, and they'll continue to do that until they turn over care to us. The receiving team can provide interventions as long as they're within the scope of care of us and at the request of the sending clinicians. Now, I want you to verbally confirm when care is transferred. Again, this is not to be difficult. It's just to avoid any misunderstandings. Now, once that transfer has happened, the receiving clinicians now have control of the patient, and their protocols dictate care. Sending clinicians have the option of continuing to provide interventions within their scope of care, but only at the request of the receiving clinicians. Now, I realize this seems a little bit unwieldy. When you understand the concept, it gets easier. So let's go over some of the more common examples. Let's say EMS responds to a cardiac arrest. We're going on a mutual aid call, and there are first responders on scene, not part of our EMS system, and they have their own medical director. Richland Hills Fire Department right now is a good example. They have paramedics who are going to be there, they're going to be working the arrest, and they're going to be using their protocols. When our EMS clinicians arrive on scene, they should communicate with the on-scene paramedics and offer to help or take over care, whatever that medic needs. Now, prior to taking over care, we can start IVs or give medications or do airway interventions as long as the sending paramedic is asking us to do it and it's something within our protocols. After the transition of care, our paramedics can request the sending medics start a second IV if that's appropriate, or do whatever seems appropriate to our medic, provided that's within their scope of care. Now, here's another example where we're sort of flipping the sending and receiving teams. Let's say we're responding to a clinic for a patient that needs transport to an emergency department. The sending clinician in this case is likely to be a physician, but they may be an advanced practice practitioner, like say a PA or a nurse practitioner. Now, the patient is going to remain in their care until we've had that formal transition of care. If the sending clinician asks that we start an IV or do an intervention, well, we can certainly do that, provided it's within our scope of practice. As an example, this would mean if they want us to intubate a kid, we don't do that, not within our scope of practice. Also, we don't intubate hypoxic patients, not within our scope of practice. Now, if the sending clinician, if that physician makes the independent judgment in their medical practice that they're going to do, I don't know, intubate the kid or intubate a hypoxic patient, they can absolutely do that as long as they still have control over the patient. But that's under their license, not my license. It's not within our scope. I hope that makes sense. This is intended to be a general approach to cover all transitions of care, and it is meant to reflect common sense in what we already do. We're just trying to get this in writing and give some common terms around it. Now, speaking of transitions of care that involve physicians like that clinic, let me give out a reminder about sending physician orders and EMTALA. Now, EMTALA does not apply to EMS. This is like a board review question. EMTALA, how does it apply to EMS? Oh, that's right, it doesn't. But EMS can still get physicians, sending physicians, into trouble. So EMTALA says that the sending physician is responsible for selecting the mode and destination of care. EMS, we're not involved in that. We don't get to change the destination. So let me kind of give you an idea. I am working in one ER. I'm taking care of a patient, and I arrange for transport of that patient to another hospital. EMTALA says I have to do an emergency medical screening exam, and if there are any emergency medical conditions, I have to stabilize those to the extent that I can. If I can't, I have to arrange transfer to a receiving facility, and I have to get an accepting physician to take that. If I order transport of a patient to X facility and I have arranged to have a receiving physician there, and you come along without my knowledge and you take the patient somewhere else, I didn't get a receiving physician there. That is a patient dump. That is specifically what EMTALA is designed to prevent. And I am now personally on the hook for $50,000. I think I can speak for all sending clinicians and hospitals when I say, please don't do that. We like the $50,000 where it is, or we don't have it to pay a fine on. Please don't do that. So let me be a little bit more clear about this because, well, to be honest, it happens more than it should, which is never. Don't let this happen.
Not now! Not ever!
But here's the scenario. Let's say we arrive for an emergency transfer from a freestanding ER or a clinic to a hospital. And we think the patient would be better served at a facility other than the one the sending physician has defined and described and arranged for. What do we do in that circumstance? Well, let me tell you what you don't do. Don't just take the patient where you think they need to go. Do the mature professional thing, which is go talk to the sending physician about your concern. And please don't do this in front of the patient. Not professional. Remember that destination, that's the physician's order. You don't have the authority to change it. But you do have the authority, and you do have an ethical obligation to the patient to go talk to that physician and discuss your concerns with them. But you can't just change the order. All right, here is another scenario. And these scenarios clearly happen. These aren't hypothetical here. You go to take a patient from a clinic to an emergency department, and you make contact with them, and the patient's like, wait, what? What's going on? You want me to go where? I'm not going there. I don't want to go at all, and I certainly don't want to go there. I hate that place. It smells bad. Their ham sandwiches, worst. Terrible ham sandwiches. Don't take me there. Well, you may sympathize with the patient, but it doesn't matter. Do not just take them where they want to go. Don't just let them sign out AMA. I don't care if they have decisional capacity. That's not what this is about. That's not the point. The point is the sending physician has ordered transport and arranged with a receiving facility to take that patient. Any changes to that order are between the physician and the patient. Now, I'm not telling you to take the patient against their wishes. I'm not going to do that. What I'm telling you to do is get the sending physician involved. If the patient still refuses transport to the designated facility or refuses transport at all, after the patient has had the conversation with the physician, then call O-line medical control for help. We just want to get you out of the middle of this. Now, if the patient changes their mind en route, well, that's a little more difficult. Pretty good chance you're not going to be able to get a hold of the sending doc, but you need to make the effort. At least try to let them know, and if you can't get a hold of them, let someone else know that we need to notify that doc after the fact. You also need to let whatever the initial facility was know that they're not going to get the patient. And you need to let either that sending doc, if you have the opportunity, or the initial facility, give them the opportunity to talk to the patient. And, pardon the dog's barking, sorry, I got cats and dogs, both kinds. Sorry about that. So give the sending doc the opportunity to talk to the patient even after you've left. In the likely circumstance you can't do that, give the receiving hospital, or at least the one that was going to receive the patient, the opportunity. Fairly decent chance that they don't want to talk either. At least put that into your chart and let them know what happened after the fact. And most importantly, let them know that you tried. The key point here is to talk through whatever the issue is with this conflict with the sending physician. If you can't do that, call online medical control and let us take you out of the middle of what I promise you highly likely to be a shit show. What I don't want you doing is just changing the physician's plans without getting them involved. Ugly, nasty, y'all don't want that. I don't want that. Let's not do it. So you can probably guess I'm going over this again for a reason. It's because it keeps happening. Please don't let it happen. As much as I enjoy making these videos, I dislike talking about this topic as much as y'all dislike hearing about it. All right, enough of that. That's it for this PIM. Thanks for watching, and thanks for what y'all do for our community every day. Take care, y'all.